What's up, everybody? Welcome back to Nursing Uncharted. This is Maggie Reichardt, your host for this podcast. And today we are going to be talking about acute care nurse practitioning. And I am super excited to talk about this because as nurses, we think about going back to school, and ACNP is one of the most, more common popular advanced degrees that you can go back for. So it's a great topic for us to have. And today we are sitting down with Dale Shaw. She is a acute care nurse practitioner who specializes in neuroscience and neurosurgery. So Dale has been a nurse since 1980, where her nursing career started in a neurointensive care unit. Her nursing career has included acute care, research, and outpatient settings with a neurosurgical focus at academic hospitals. She has been an acute care nurse practitioner since 1999, working with adult acute care neurosurgery patients. And she was actually one of the first ACNPs in the university hospital where she continues to work. So Dale, welcome to the show.
Thanks, Maggie, for having me.
I'm so happy to have you here today.
I'm
Dale,
excited.
Yeah, this is great. Dale and I used to work together in neurosurgery, so I know how important she is to the betterment of inner workings of her unit. And she's one of my first favorite NPs to date to work with. So I just appreciate you sitting down with me to talk about your job.
Thank you.
So just to start out, as far as becoming an ACNP, just tell me a little bit about the history of ACNP and how you came into that role.
Yeah, so I, as you said before, did some other roles after leaving the ICU, and really missed bedside nursing and missed working with nurse colleagues, which I wasn't getting that kind of feedback or enjoying it as much in other settings. And so I went back to the bedside on the acute care side and was happy to be there. Considered getting my master's, but I didn't really want to be in a teaching situation away from the bedside. Didn't really want to be a clinical nurse specialist because, again, saw that more as a problem-solving role for systems. And so really until the ACNP program came about, I just wasn't interested in anything because I didn't want to leave the bedside.
Yeah.
And then about 3 years after going back to the bedside, the ACNP program started at the university where I work. And that to me was just like the perfect position. So I applied and I continued to work full-time and went to school part-time. So it took a little bit longer. For me, it was a good 3 years.
Okay.
But again, I was going to school part-time and I was working full-time. So, and now you can actually go and get your ACNP and your doctorate of nursing practice together, which is 3 years total full-time. But you walk away with a doctorate and you have a good research background.
Yeah.
So I think
that is so important.
It is. And I think that if I was advising somebody to what route to go, I would tell them to go through with the DNP because you just can get all of it at one time.
Yeah. I mean, it makes sense. We base so much of our practice onto research. You want to have that underlying background.
Absolutely. And the other thing is you want to contribute to the nursing research. And what better role than somebody who's at the bedside, right?
Yeah.
To actually do research at the bedside where you can then disseminate it through the rest of the country and make changes to taking care of patients. So that is, makes it even more exciting.
Yeah.
And then you're also including the nurses at the bedside in that research so that they get a taste of that.
Right. Yeah. And that's kind of, it's empowering for the unit to be a part of those projects. It helps you solidify, a culture there and, holds people accountable and makes them proud of what they do. So, I mean, research on the unit really, I feel like strengthens units.
It does. I agree with you completely. And also, we talk about evidence-based nursing and making sure we're using evidence-based nursing and we should be contributing to that evidence, right?
Yeah.
So that we're all still practicing that way.
Yeah. I think when people think about research, they don't think about evidence-based practice in nursing a lot of the time, but everything that we do from, preventing infections and central lines and just washing hands and mobilizing patients. I mean, all of that is research-based,
Absolutely. Absolutely. And even the way we take care of wounds, the way we position patients. And I mean, look at during COVID about the proning positions. I mean,
Yeah.
that was really an evidence-based practice that
Yeah.
was used during the COVID pandemic to save patients' lives.
Yeah.
And so, that's a really good example to me of bedside nursing research that can be
Yeah.
used.
Yeah, absolutely. What about as far as schooling? Is there like how did you specialize in neuro during like did you have to choose that during school or did you how does that work?
Yeah, so I did actually. They actually ask you to sort of, knowing that you can change your mind at any point in time, they ask you sort of to specialize in that so you can set up your clinicals
Okay.
so that, that you're getting what you need for your practice.
Sure.
But it's also kind of a great time to throw in a couple of clinicals of things that you're not so good at. Like for me, pulmonary was not a strength. I had been a neurosurgery nurse and I had taken care of patients with ventilators, but not really pulmonary.
Sure.
And so I did a MICU rotation to kind of benefit me with that strength that I didn't have to begin with.
Yeah.
And then, so I think that's important too, is to not just specialize, but also open yourself up to other things that you can strengthen your
Specialties.
practice.
Yeah. Yeah, absolutely. It's definitely been, I mean, when I was traveling, I started out in neuro, but then you kind of prioritize what kind of jobs you want. And then you end up, finding yourself in a different type of specialty, all kind of in acute care. But, I took a couple neuro jobs and then I took a head and neck job and cardiac. And it was kind of like, oh, okay, I don't know anything about that, but
Exactly.
I'm just going to follow all my orders and hope that, hope for the best. But it really, after 4 years of doing that, it really expedited my nursing experience. Cause it's so important to introduce yourself to, I feel like a jack of all trades now,
Absolutely. And, you don't, all our patients that come through, I mean, they may have neurosurgery, but they also have other medical problems that I need to take care of. And so, you really do have to strengthen your education taking care of those patients.
Yeah.
And then I also, I did a little clinical in the EP lab because I knew nothing about anything. And I just was like, people talk about it. I have no idea what they're talking about. So
it's electrophysiology.
Uh-huh.
Yeah. Okay.
And like, pacemakers and,
Sure. Okay. Yeah.
AFib. And so I knew nothing about that. I was like, I should really take advantage of this opportunity and go ahead and learn something about it. So when my patients come in and they talk about what they've been through, I have some idea what it's about.
Yeah. Yeah, absolutely. Getting that full rounded. So did you have to do clinicals in the outpatient setting also during your?
I didn't have to, but I did. I did it in the neurosurgery clinic. And I did it because I felt like it would really help my physical exam. Because, when patients come to the hospital, we already have a diagnosis for them most of the time. Maybe not on a medicine service, but certainly on a neurosurgery service. We have a diagnosis or working diagnosis.
Yeah.
When patients present to the clinic, they're presenting with either pain or some sort of deficit, and you don't have a diagnosis. So I felt like it would help my clinical physical exam and also history taking by doing the outpatient because I was starting from scratch.
Sure. I think it must have also, too, just helped you kind of formulate a whole big picture and seeing patients not just inside, their 4 or 5 day course, but seeing them when they seeing the whole picture.
Yeah. And also I got to see patients come back, which I never see, right? In the hospital. So, a subarachnoid hemorrhage that we sent to rehab, I got to see come back in clinic and look fantastic. And so that was kind of rewarding to see those patients in the outpatient setting.
That's such a thing that we miss in inpatient that I so wish that we had. Is just that feedback, that kind of full circle, they were a spinal cord or, they went to rehab and now they're doing great. And, you know,
Right.
I wish that we had that ability to know that, like, we're still thinking about you guys.
Yeah, it's true. It's true. That's why I love when patients come back to the hospital to see us. And they never remember us, of course, but
Yeah.
we remember them. And so it's
Right.
wonderful.
There was a guy I remember who was a traumatic brain injury, and he was, I mean, you know how TBIs are. I mean, he was like a classic. He was labile, behaviorally labile. I think he headbutted a nurse. You know, he was in 4-point restraints at one point. He was just all over the place. And he went to rehab, and then he came back to the unit walking, just a normal guy. And I was like, I'm so happy. This guy pulled a deer out of the road and got hit. And
I remember, yeah.
you remember him? And
Yes.
I mean, I was so happy for him. And it's just amazing what the body can do and
It
like
is
how it can
amazing.
heal. You know, I did one rotation in a rehab, and that kind of really helped my full circle too. I mean, just being able to see you're seeing those patients for like 2 or 3 weeks as opposed to a couple days. But like the improvements that they can, you know, have within a matter of days, it's incredible. And it gives you a little bit of validation and satisfaction for the work that you're doing.
It definitely does. I mean, it really does, especially for like those TBI patients, which can be hard patients to take care of, right?
Yeah.
And then to see them come back and see how well they're doing, it makes all of it worthwhile.
It
Like
does.
everything worthwhile. Like the good and the bad worthwhile.
Yeah. There was a guy, another patient who came back to the unit, and I think, and I mean, I think he was a subdural, and he was just kind of a little inappropriate, but just more confused. You know, I didn't fault him at all, but he came back but his family did. They were like, you just wait until you're orienting again. We are going to tell you about all these things that you said. And he came back to the unit, and I remember him being like, I really appreciate the care that you provided for me, and I'm so sorry for any, you know, thing that I said or did. I was like, I'm just happy that you're well, you know.
Yeah, it's so true. It does. It makes the bad stuff seem really good, you know?
Yeah.
It really does. And to know that people didn't give up on them. That's the other thing.
Yeah.
You know, we don't give up on people, and we just know that they're going to turn around.
Yeah. It takes a really special, I mean, I think neuro patients are some of the hardest patient populations there are because of that factor, because of that, you know, constant need to have like a selfless, you know, empathetic mindset for these people that don't mean what they are doing or say, and they're not in their right mind, and they're very, you know, irritated or overstimulated, you know. It takes a lot to take care of those people. And so it's, you know, it's a difficult, you know, it's a difficult population to take care of sometimes.
I think it is too. It is too. And I think also, and I say this all the time, I think, you know, we don't get good neuro in school. Nobody gets good. So it's a little overwhelming when you get out of school if you're taking care of a neuro patient, because you don't feel very well trained to take care of them. And I think people get nervous and scared because they don't really understand neuro patients, and you just have to kind of jump in and take care of them and learn about them. And I think that's why it's so important, like when we get new nurses on the unit, to really invest in their education so that it's not scary. You know?
Yeah. That's a good segue, because I want to talk a little bit about the patient population that we see in neuro, because a lot of people get intimidated by neuro and how specialized it is. And a lot of people don't get to see specialized neuro patients on their floor. So help me do a little quick rundown of like a normal neurosurgical neuro population.
So I think we'll start from what people would consider the easiest patients first, and those are the spine patients who have, you know, herniated disc or spinal stenosis, and they're getting fusions. They may or may not have deficits, being that they could have leg weakness. But then there's the medical kind of neurosurgical emergency, and those are the patients that have cauda equina from a compressed nerve root, and of course have urinary retention. And those are the patients that even could be very young patients and have very devastating, even though they're walking, they still have a devastating injury. So those are a lot of our patients. Spinal cord injury patients, I think, are also one of the most difficult patients to take care of, in that it is such a devastating injury. It's an injury that changes everything about that person. Everything about that person. Where they thought they would be in the future, they won't be there in the future. They have a different future. And so I think from a physical and emotional standpoint, those are also some of the more difficult patients to care for.
We will be right back to this episode. We just want to take a brief moment to shout out the company that makes this show possible, American Mobile. If you're a nurse interested in traveling, visit americanmobile.com to explore the amazing benefits that American Mobile has to offer. Featuring short and long-term contract opportunities at leading facilities across the country with higher earning potential, W-2 employee status, and a flexible schedule, American Mobile is your advocate for career success. Visit americanmobile.com to begin your travel nursing adventure today. And now, back to the show. Yeah, they're also some of the most heaviest education-wise and, nursing heavy,
Yeah, because it's total body. Every system, you are taking care of every single system. And there's not a lot of medical things that can be done for spinal cord injuries. It's all nursing. It's all nursing care. That's what changes the outcome of a spinal cord injury patient, honestly.
Yeah, so true.
And then you have the TBIs, which we sort of talked about, but along with that is also the subdurals, the subarachnoid hemorrhages from aneurysms, or the subdurals is your 70 and 80-year-old person that's fallen and has tons of comorbidities that you're also managing. And they're also, it's kind of like a fork in the road for some of these patients of what happens next to where they go from here. Right. So, they may not be able to go back home.
Discharge planning is so huge.
It is.
Because a lot of times it's like, okay, why are you falling? You are probably in this pivotal point in your life where you're at a crossroads and, your family isn't around, but you can't take care of yourself anymore. You can see these acute on chronic subdurals. It's like something has to change.
And sometimes they're the caregiver. They're the caregiver for their spouse. And then they've, had an injury that has changed everything for the whole family. So those are definitely some of those patients. And then we have the aneurysmal patients that have subarachnoid hemorrhages that also can be quite devastating and usually tend to happen in a younger population, meaning younger than 50. So as far as deficits and rehab and disability is a big thing for those patients as well. And they can also be primary caregivers, or they could be primary, wage earners and things like that. So again, most of them, except for the elective surgeries, most all of them are change people's lives. And and then we can talk about brain tumor patients, which also does the same thing. I mean, the outcome's not always positive, but a lot of times it is, and it's just getting them through the recovery.
The brain tumor patients, well, I wanted to ask, what do you think is what type of population is the most interesting to you? I mean, like the most kind of stimulating to you?
I think I think some of the brain tumor patients are really the most interesting, especially nowadays. There's so much information about brain tumors and we're learning so much, and as far as the pathology, and I can't even begin to explain all that they're finding out about brain tumors and just the histology of it and pathology of it, and then the treatment of it. So for me, I think that's really exciting. Because I don't think it has I feel more optimistic, let me say, than I may have previously felt. And then the pituitary, where we work is really have a lot of pituitary tumors, and they're always very interesting because I sort of like endocrine. And so they have all those endocrine problems that you have to figure out. So I think those are a nice population to take care of as well.
I worked in New York City in an endocrine clinic for 3 months, and there was a new endocrine attending that needed a nurse, and she was like pituitary and neuroendocrine. I was like, I want her. And I was like, because all of this stuff is so interesting. And she loved having me because she knew, like, I already had a background in pituitary patients. And, as a traveler, you can't really, be on the lookout for neuro-specific CNRNs with pituitary experience. So it was a great match. But yeah, they are so interesting. I mean,
it's so interesting.
It's crazy how much your pituitary is responsible for so many different hormones. And when that's like a functioning macroadenoma, like everything is just out of whack. And, they are probably, the most interesting and complex.
Yeah. And the other thing about those patients is that I find that they come to us with some hesitancy about the medical profession because a lot of times their symptoms have been going on for quite some time, and it takes a while for them to get diagnosed. And so they're usually very they've read a lot. They're very caught up on their own care and what their own endocrine problems are, and they're very educated about it. But there's some distrust because they have been, it's taken a while for them to get to where we're seeing them, because sometimes the symptoms are very vague when they first start out, and it's just hard to diagnose them. So you have a patient that has, all these problems, and they have a little bit of a distrust with the medical system. So it makes it even more challenging.
Yeah. Well, when you have one problem that doesn't, it's affecting a system and not like headache or vision changes or balance or, it's like you go to that one specialized doctor and then they think it's something, and then you go somewhere else and they think it's something else. And I can totally, I totally sympathize. I understand that. But I mean, I think the thing about brain tumors is like you can see it and you can treat it.
Right.
Like that's kind of like, there's so much in medicine that it's like, we don't really know, but I mean, those things, it's like satisfying in that way. Like, okay, this is the,
this is the problem. This is what we have to do.
Yeah. Right. So yeah, that's very true.
Yeah.
As a floor nurse, floor nurses don't really get to understand like the day-to-day schedule that nurse practitioners and interns and residents have. We'll kind of interact at different points in the day, but just to get a sense of like what your day entails, talk to me a little about what your normal day looks like for you on the floor.
Okay, so I usually come in pretty early in the morning because the neurosurgeons are going to go to the OR, and we need to have a discussion about what the plan is for the patient. So I tend to come in around between 5:30 and 6 o'clock and look at the patients that are on the floor, go through what's happened during the night. I love going in also early in the morning because I talk to the night shift about how was their night, what happened, what happened with this patient, especially like the TBI patients, or did they sleep, So like, how was the patient's night, and also how was the nurse's night? So that's one reason I go in really early. And then, so I go through the patients, and then we do what we call a sign out at 7 o'clock. And that's where all the residents have already rounded with their attendings. And then they give us the plan from the attendings viewpoint, and we can have discussions. So if I have a question about a patient, say, when are we going to restart their apixaban, after surgery? That's the time I can ask that question and then plan for the day for the patients. And then I go see all the patients that I'm taking care of. And then we have interdisciplinary rounds where we meet with PT, OT, social work, case management, and talk about disposition and discharge planning. And then throughout the day, I just see all patients, look at labs, look at any testing that we've done. So if we've ordered a CT scan, then I'll look at the results of the CT scan. talk to families, talk to the patient, give them the results, collaborate with the patients and the families about what their plans are for the day and what they hope to accomplish, their goals. And then we come up with a plan. So, like if it's walk 3 times today, it could be just walking 3 times, but that's like the plan. And then of course, emergencies happen sometimes, hopefully not that often. And I have to say, I feel like we're on top of things a lot, that things are not really surprising. Nothing, it's very rare that there's a surprise.
Yeah.
But it does happen. And so that can always change your day. But then I mostly try to get patients discharged by a reasonable time. And so that then when the post-op patients, I'm ready for them when they come up. And then it's assessment, going through med reconciliation, talking with families, the patient, and kind of making a plan, like Foley's coming out or not coming out and why, and that kind of thing.
Yeah.
So, and then throughout the day, I'm speaking with nurses to tell them, they're telling me, we're collaborating with the care of the patient. And I'm very, very much in favor of nurse-driven everything.
Yeah.
So it's not me putting orders in, it's us talking about what we're going to do for the patient.
Sure.
That to me is the important thing. I'm not going to order an enema for somebody if we're not going to talk about it, and you're going to tell me what's been going on. That seems like a silly thing, but it's not a silly thing,
Right.
So just collaborating with that. And then also with my residents, we call running the list. So we run the list about midday to see what still needs to be done as far as any consults or testing. And then before we leave in the evening, we do a sign out with the resident that will be on call during the night, so that they're fully aware of everything any concerns that we have about patients, anything that still needs to be follow up on, and then come back and do it the next day.
Yeah, right. I guess I didn't realize how, it's very similarly parallels with the floor nurses' days too. There's a lot on the front end, and you're like getting your day and figuring out the goal and the plan, and you're talking to other teams, and you get your assessments done, and then you just wait for the rest of the, you just respond to, needs, and then you try to discharge patients, and then other patients are coming in, and you're trying to, it's pretty
new for everybody. Yeah.
Yeah.
So I sort of describe the acute care nurse practitioner as the center of a wheel. And so the nurse practitioner is the center of the wheel, and all the information is coming through the spokes to the nurse practitioner. And then she's also taking all the information out to the spokes to the other people. So consult services or radiology or nurses or, therapist, physical, occupational, speech. So that's how I envision the role, as being the center of the wheel. And then everything's coming in and going out from that center.
Yeah, that's a great analogy. Great way to put it. I feel like nursing, a lot of times, I assimilate it to the switchboard.
That's a good one. Plug in.
You're the ones that's like, okay, this is a change. I got to contact this person. This person, needs to work with PT. You got to contact them. Oh, they think they can swallow. All right, contact speech,
Or they can't swallow contact.
Speech. Yeah.
Yeah, so that's the way I look at the nurse practitioner role in acute care, is that center of the wheel.
Yeah. Well, really cool.
And then you have families too, and patients and everything too. They're part of that.
Yeah, absolutely.
I like your switchboard.
Yeah, you can use that.
Okay.
I just think, I remember coming off of orientation as a nurse, and when you didn't have your preceptor to kind of be the gatekeeper for a lot of those people. And I remember the extreme shift. I was like, oh, everybody is coming to me about whatever this needs to accomplish. I'm like, I'm the person that has to like put all of this in my brain and remember to tell whoever and document it all. And so, yeah.
Really not that different. I'm just telling you, it's not
Yeah.
that different. It's just, it's on a different scale, but it's not that
Right.
different.
Yeah.
It's, I can remember the first time writing a prescription for narcotics and totally freaking out because I was like, who said I could do this?
Right. But you also had you had that background and I think that's another, it's important to get a little bit of that floor experience too before you go up to be an NP because you know what to order,
Absolutely. And also, I'm probably a little prejudiced about having experience going into the school, but you also bring a lot to your colleagues in school, right? So like if you've been working, right, in your experiences, then in that classroom or clinical setting, you add to that, right? Because you have things to bring to it. And so I also think it makes you a better student and student colleague.
Colleague, right. Yeah, that makes total sense.
Because when you're in school, you're presenting a patient to your colleagues, okay, out in the hall. This is what the medicine physicians do, right? They present the patient and they talk about the patient. Well, you're also talking about the patient, and it may not be your patient, but you have something to offer because of your experiences.
Right. Yeah.
In the care of that patient that maybe somebody else hasn't thought about.
Yeah. So true. I think that's one of the beautiful things about teaching hospitals too, and university hospitals, is that you have so many minds that are, working together.
I think it benefits patients. I really do.
Absolutely.
Because what my strength is and what your strength is are different things. And so we're going to see the patient in a different way. And we're going to have something different to offer them.
Yeah. As someone who's been working in the same place for most of their career, I feel like you have a unique ability to kind of be the constant in an ever-changing environment. You have the knowledge of what's been in the past versus where we are now in terms of nursing practice. And, with that in mind, I'm curious to know, in your opinion, what you think some of the most notable changes have been in nursing over the years.
Well, that's a really good question. I think it changes. I think nurses have a little bit more autonomy, definitely more autonomy than they did before. I see the nurse as the patient, is patient-centric. And like you said before, being the switchboard, everybody comes to the nurse. Yeah. And the nurse is really directing care. That's the way I see it. I think we're more collegial than it used to be. It used to be more physician dominant. I don't see that. I see that changing. Yeah. And I think we're all taking care of the patient. It's a team.
Yeah.
So
it's more team oriented.
It is more team oriented. And I definitely think that's a big change for us. And that's happened probably over, I would say, 15 years. That's been happening.
Okay.
I also think the complexity of patients is astounding.
If you used to be very cut and dry, like, this is the problem, we fix the problem. Yeah.
And patients, I know everybody thinks that they take care of the sickest patients, but patients are sicker. I mean, they have a lot more comorbidities. And so their care is a lot more complex. And so you may be on a neuro floor, but you're taking care of somebody with peritoneal dialysis and they have diabetes, they have an EVD on the floor or a lumbar drain. It's not your laminectomy that comes in, has surgery, and goes home. Those patients are outpatient now. Those patients may spend the night, but they're home the next day. Yeah. Those aren't the ones that stay in the hospital. So the patients that stay in the hospital are a lot more complex and have a lot more needs. And I think nurses have to be a lot more educated and supported to take care of these complex patients.
Yeah. That's really interesting to know. I mean, I remember, you hear, as a younger nurse, you hear about, stories of nurses taking on like 11 plus 12 to 15 patients. And I think about, like, how how I couldn't, like, I, but I think that there's a lot more, complexities. I feel like now that there's a lot more that we are required to think about and do in our day to day. And I guess that makes sense that they probably, realize that and cut down the amount of, safe patient care.
Absolutely. And not to take away from those of us that did take care of 30 patients or however many patients, you didn't have time to actually really look at the patient, right?
Yeah.
You were checking boxes off. I mean, that's the way it was. And, I think we gave good care, but we didn't check labs. We didn't have time to check labs. So what does that mean? If we're not checking labs, or, an intern who has also the same amount of patients. So I think the care is better because we aren't taking care of so many patients.
Sure.
And I think I won't even try to get into like how you figure out staffing. I think that is such a controversial subject.
Mm-hmm.
But I think it needs to be one that the nurses drive and no one else does.
Yeah. I have kind of, going into the ICU setting, but having the acute care background, the busyness in the day is very different. I mean, you really trying to provide really great quality care to 4 people is difficult. I mean,
it
can
is difficult,
especially with complex patients and patients that can't get up on their own and they can't eat on their own. I mean, neuro specific patients are very, it's amazing when you can't get up on your own and you can't do those like normal activities of daily living. That takes a huge chunk of time out of your day to do all
it's a hard
things.
workload. It's a big part of your workload, right? Yeah. And then assessing the patient and also figuring out, should I give this drug or not? I mean, right? That's part of like what you're making those decisions of, I don't think I should be giving this. Now you're going to talk to your NP colleague or your physician colleague, but you're the one that's bringing it to them, right?
Yeah. Yeah.
So,
right.
That's part of like, and then all the other things that go along with it. You have just think of a patient that has DKI and with that one patient, and that's one of your 4 patients, that's a lot of work.
Yeah. Yeah, it is. It's a lot to remember, and it's a lot to like, you have the responsibility and the accountability to be autonomous and make the right decisions and communicate them to everyone else. But also in that moment, it's like, okay, this is ordered at this time, but this doesn't seem right to me.
Right.
Instead of just like, well, the doctor said.
Right.
So that's, yeah, I could see that being a big change.
And also, I mean, let's just bring it into neuro, okay? Who's at the bedside and sees this patient? Nurses, all right? Mm-hmm. Neuro patients can have such subtle changes that if the neuro nurse doesn't pick it up, it's not going to be picked up, right? Yeah. And like, honestly, it could just be from someone who knew that they were in, Virginia, like 2 hours ago and now doesn't. And somebody could like dismiss that as that they're tired or whatever.
Right.
Right.
Pain meds or,
Yeah. And if you're not bringing it forward to the appropriate people to like start investigating this, then it's not going to happen. Yeah.
And communication is so key. I remember, when neuro-ophthalmology comes around and they like do an assessment and then they dilate the pupils and you come in there and you're like, because they're like 8 and fixed, like communication is so key.
It is. It is key. They still do that.
Yeah, they just come right in there and they just drop a couple eye drops in their eyes and leave and just give you a heart attack.
Exactly. Freak you out for the rest of the day.
Yeah. Oh, gosh. Well, I want to talk about something really special that I've never seen on other units or nurse practitioners doing, and it's that you incorporate it into your ACNP practice, which is nursing education rounds. So can you explain to listeners what nursing rounds are?
Yeah. So when I was in school, I loved that the ACNP students would stand talking outside the patient's room. Sometimes we'd go in the patient's room if it was a patient that could contribute, right, is awake and everything. And we would talk about patients, and we would look at films, and we would do all these things to have a total understanding of what was going on with the patient. And then having this group of people also come up with different ideas of how to take care of the patient, right?
Mm-hmm.
We don't do that a lot with nursing. We really don't, right?
Yeah.
We don't like sit in a group of nurses and talk about taking care of patients and asking questions about what would you do in this situation. Like, we don't have the opportunity. And that bothered me. So that was one thing. The other thing is I was fortunate enough when I worked in the neuro ICU as a new grad, that the medical director would come in at like 2:00 in the morning and throw up CT scans. This was before we had PACS.
Cool.
Or well, we didn't have MRI at the time, but throw up CT scans, would teach us about the films and and connect neuroanatomy and with the films. So I thought, that was something also that we don't get as nurses, right? So I just decided we were going to do this. Like, we're just going to do this. We're going to have like a half an hour. It used to be twice a week. I would do it Monday mornings, like at 4:30 in the morning, and then Wednesdays at 1:30 in the afternoon. So I'd get the night shift and the day shift. And now I just do the night shift once a month. Sorry, I'm just older. But it started off that I would ask them who the most vulnerable patient on the unit was. And vulnerable could be anything. It could be a diagnosis. It could be someone who doesn't speak English, which makes them vulnerable, right? It could be somebody who's homeless. So, it could be anything that made them vulnerable, but that's how we would start the conversation. And I did keep it to neuro patients because I also wanted to talk about the whole patient. So that's how it started. It was talking about the most vulnerable patient. And usually I found, like, if you ask me what are some of the best nursing rounds that I've done, those would be the ones I would tell you, because a lot of times it was the difficult patient, the difficult neuro patient that we would talk about. And then we would talk about what the patient was going through. So I'll just give you a quick example.
Yeah.
I talked about this really young guy who was like 24 years old. He was on a motorcycle. He was in an accident. He fractured C3-4 and also got a brachial plexus injury. So he was neurologically intact from his cervical spine injury, but he had a brachial plexus injury, which means he couldn't use his right arm at all. Of course, he comes into the hospital. We do surgery on him, fix his spine, and can't at this point do anything for his brachial plexus because they tend to wait and let things calm down before they see if they can fix it.
Okay.
So we're talking in nursing rounds, and he was kind of he was a little angry about what he was going through. And everyone was kind of like, he's so lucky. And so I was like, yeah, I know he is. He could have been a C3-4, spinal cord injury. Like, he is so lucky, except for he can't use his right arm. Do you think he thinks he's lucky? He doesn't think he's lucky. Yeah. Because he doesn't know he could have been a spinal cord injury, right?
Right.
He doesn't know what it could have been. He only knows that he can't use his right arm. And for whatever reason, whatever his goal in life are, he doesn't have a right arm that he can use.
Yeah.
So kind of changing the perspective, right? Changes then the way we approach him.
Yeah, change his care.
It does, because you can totally put yourself in his position, and it does change. It changes our approach to him. So those are the ones that I tend to remember the most. But I do so I do one or two things. Like, I either have the nurses present a patient that they're taking care of and talk about their deficits. Okay. And then have everyone try to figure out where the lesion is or what's going on. Like, what's the diagnosis? And I make them go through everything, like from zebras to the most obvious, right? And so everyone kind of shouts out, oh, it's probably this or it's probably that. And then we say, well, why? Why do you think it's maybe this? And they would be like, well, I think it's, an infection because he has a white count and he has this and that, we talk about it. And so then I throw up the CT and the MRI and we see where it really is. And most of the time they know exactly where it is because they're neuro nurses, right? So sometimes I put up a film or an MRI and I say, okay, here, and we go through all the nurses know how to read CT scans. because they've been taught how to read them. And so we'll throw up a film and we'll say, like, what do you see here? And they'll describe what they see. They won't diagnose what they see, they describe it. So there's blood, along the right outer edge of the brain with a shift, a 5 millimeter shift over to the left. And there's blood in the frontal lobes, so they'll talk about it, they'll say it. And then I say to them, what do you think their presenting symptoms were? And so try to take it from the other way, having the film and then trying to come up with how the patient looked and doing it that way.
Those are some of my favorites, because it really makes you think so much. It makes you put all of the pieces together, and you're really, the continuing education piece was just so valuable for me. And I know it was so valuable for everybody else too.
Well, and also, it's hard when you're neuro is kind of like putting, understanding cranial nerves and what affects what cranial nerve and why that cranial nerve is affected, or why is somebody weak in their arm but not in their leg, trying to understand, or they have a facial palsy, but it's not their eye, like a stroke would cause a lower facial palsy, right? Not their eye. So trying to put those together. And then also, I think most of us are visual. So to visually see where something is and then put signs and symptoms together, I think just you remember it then, right?
Yeah.
So then when you're getting a report and you get a report that your patient, had a right craniotomy for a frontal, hemangioblastoma, you're going to kind of know what you should be looking for on this patient, right? Because you know where it is, you know what it is, and you know what you should be looking for.
Yeah. Yeah.
And it's just more valuable, right? In caring for the patient.
Yeah. You feel it provides so much for the nurse and for the patient when everybody understands what's going on. You just get so much better care, I feel like, when you're if it maybe something happens, and instead of having a fear of not understanding your patient, because that's very real as a nurse, just being able to have a little bit of peace knowing, this is normal for that patient, or this is something that we talked about that we can anticipate happening.
Exactly. And that's usually what happens is that, we'll talk about a patient who's in the ICU that's going to come to the floor. And so we'll go through those films and their course through the ICU, so they know exactly what to expect when the patient hits the floor. Yeah. They know what to look for. They know, I presented a patient on Wednesday who was having surgery the next day and then going to go to the unit and then coming back. And so I was like, so what do you think what do you think complication could happen with this patient? And it was that the patient could develop hydrocephalus. Well, they know what to look for, right? They saw the film. They know exactly the patient. They know, oh, this patient, I need to be aware that might get hydrocephalus. And these are the things I need to look for. So it just makes it so much better. And then, or you can hang up a film of somebody that's had a, T1 through iliac fusion, and you see all the instrumentation and you say, yeah, I can see why they might be in pain.
Yeah, right. It's all of that. Yeah, I see that.
That would hurt.
Yeah. Yes. One of my favorite nursing rounds, and it's applicable because I've told my husband this story, but I remember there was a patient that you presented who came in. She came in with behavioral changes. I think it was she came in with a sinus infection. She went to the emergency room for a sinus infection, and she was prescribed Flagyl and went home. She was having nausea, and so she stopped it. And then probably over the course of, a week or so, she started developing behavior changes. And I think what made her come into the emergency room is she was screaming on the hood of a car or something. And they brought her in and they did a scan, and she had an infection in her frontal lobe. And so they did triple antibiotic therapy and, cleared it up. And what had happened was she had a ruptured eardrum. and she went scuba diving, and she got an anaerobic bacteria in her eardrum. And my husband has a ruptured eardrum, and he used to have chronic infections. We're like, no scuba diving for you. You are not. That is, I'm not doing that. No.
We're not doing that.
Yeah.
That is not on the agenda.
But I just remember, like you said, you go through the process of like, well, what do you think might be on her scan? Or maybe you pulled up the CT scan and you're like, so how do you think she could have presented? And just making making all the wheels turn in your brain. It's something that, was invaluable to me. And I know that it has a long-term impact on the nurses there. So.
Yeah, I think to me, it's probably the most important thing I do, honestly, because, it's sort of like if everyone is informed and everyone knows how to take care of patients, right, then patients get great care, right? Mm-hmm. So it's like you're just like have this big group of people that can then manage a lot of complex patients. But the other thing is that they get it. Like they really know what's going on,
Yeah.
It's like, it's not just steps, it's thinking, it's critical thinking and developing those critical thinking skills. And also I think it gives a lot of autonomy, and because you can bring a lot to the table and a lot to the discussion. Yeah. Right?
I think that's why I've always considered the nurses that come out of that unit like Spartan nurses. I think, and it's because of that motivation to teach and make them confident in their nursing ability and, autonomy. And it's because of things like that, things like the nursing round. So, I'm hoping, with having you on and talking about this, that might inspire another nurse practitioner that's specialized in something else to really empower their nurses to, and continue that education, just because of how invaluable I've thought it was on our unit and how you saw the long-term impact of what it did for the culture. So.
No, I think it's really important. And I would love for it to be everywhere. I would really love for it. And, in the ICU setting, there's a lot of teaching rounds with the teams. Mm-hmm. You don't get it in acute care setting. You really don't, because the opportunity isn't there.
Yeah.
So in a way, I think it's even more important for acute care nurses to have some sort of forum that they can have this, where they can learn and ask questions and have it be very, very easy, and non-judgmental. Like no one has a wrong answer. There is no wrong answer.
Yeah.
There's just different ways of thinking about it.
Yeah. Yeah. What are some of the most gratifying aspects to you think, in your profession of being an acute care nurse practitioner?
Beside having the nursing relationships, I think is having patient and family relationships. Sometimes I'll be sitting in a room talking to a patient and a family, and I actually get chills that go up my spine. Like, cause I know that it's just happening, there's a connection and they're feeling good about things. And I get chills that go up my spine, and I walk out of the room and I just think, oh, that was like amazing.
Yeah. I'm sure. You have such a great bedside manner, and that's so needed in those types of patients that are being, they're right in the middle of this profound point in their life. It's so valuable to them to have somebody that really cares about making that relationship.
Yeah. And also knowing that they're going to get answers. I think that's really important, especially, for surgeons or in the operating room. A lot of families never get to see the neurosurgeons, because of their schedule. And so to think that they're going to have to wait for answers is really, that's hard for them. Yeah. And so knowing that, if we're going to get a chest x-ray, I'm going to come back and tell them what the chest x-ray showed. They don't have to wait for that information.
Yeah.
And I think that also, that gives me a good feeling, because I feel like the patients and the families know what's going on. There's no questions then.
Yeah. Yeah, absolutely. Do you think this episode really is about people interested in ACNP. You know, for a listener who might be interested in ACNP, do you think that there's a set of characteristics, or what would behoove somebody to become a strong ACNP? Is there things, you know, in your toolbox that you should have to be a strong ACNP?
So I think if the first thing that comes to my mind is approachable. Like
Mm-hmm.
you have a lot of people coming at you a lot, and it can be somewhat stressful. But if you just have to have an approachable personality, because
Mm-hmm.
if you have a standoffish personality, it affects patient care, right?
Yeah.
Because people will be scared to come to you.
Yeah.
You can't be
Absolutely.
like that. It can't be like that. You can't be scared. I mean, I think you can be honest and say, "Oh, I'm kind of like a little overwhelmed. Is it something that can wait, and I'll come find you?" I think you
Mm-hmm.
can be like that.
Mm-hmm.
But approachable has to be key.
Yeah.
Key.
Yeah.
So I think approachable, I think you have to you can have high energy, but you also have to really take things in stride. And being a nurse is like that, right?
Mm-hmm.
Like
Yeah.
no day is like the day before. No
Yeah.
hour is like the hour before, right? So you have to be flexible and you have to really take things in stride and just say, I'm going to do the best I can here and it's going to be good.
Mm-hmm.
Right?
Yes. We're going to make it a better shift than last shift, because last shift was rough.
Exactly. And it's going to be really good. So maybe optimism must be one of those qualities too.
Yeah. Yeah.
And I think you also have to have leadership.
Mm-hmm.
And also you do have to be somewhat confident. And that doesn't happen overnight. That doesn't even happen in school, but you have to have know that you're well trained, that you have something to add, and that your voice is very important. So, you just kind of have to know that, because you're going to stand up for a lot of people, So I think those things, and then of course, empowering other people is a good quality to have.
Yeah, absolutely. Well,
and be somewhat intelligent.
A little bit. Well, I think you check all those boxes, Dale. So.
Thank you.
Well, I am just so happy that you came on and we had such a great, great conversation. I knew we would. I was so excited for this episode. So
I was excited too.
But thank you I think we're going to end it here. So Thank you so much for being on, and we'll talk to you soon.
Thank you for asking me. Okay. Thank you for asking me. Take care of yourself.
Bye.
Bye.
That brings us to the end of the show. Thanks for tuning in to Nursing Uncharted. To learn more about today's episode, make sure to explore the show notes at americanmobile.com/nursinguncharted. And don't forget to subscribe so you never miss a guest. If you're a nurse interested in traveling, visit americanmobile.com to explore the largest database of travel nursing jobs in the industry and the amazing benefits that American Mobile has to offer. Also, a special thanks to producer Jonathan Carey, assistant producers Katie Schraubin and Sam McKay, and Aidan Dykes for the music and editing. Until next time, take care of yourself.